So welcome to Plainfield Public Library. We're very happy to have Regional Cancer Care Associates partnering with us for this program. And what we will do is after the meeting, once I get the link up on our YouTube channel, I'll go ahead and send out an email with the recording to everybody who registered. Even if we don't quite get as many people able to sign in because of the technical difficulties. The last presentation we had on pancreatic cancer, took us a little trouble getting the technology up, but we do have the recording up on the Plainfield Public Library's YouTube channel now. It's a very interesting and educational presentation. Dr. Pond, do you mind if we start now and we'll just hope that other people come on back in, or will you want to wait a little?
Oh, we can start.
Okay, so I'm going to go ahead and we're recording and we'll go. So here we are, Lunch and Learn with the Doctors. And this is you. You are Dr. Ching Pan. And you're with Regional Cancer Care Associates of Central Jersey. And I'll let you go to it. Let me know when you want me to advance the screen.
Okay, sure. Good afternoon, everyone. First, I would like to thank Plainfield Library to give me this opportunity to present colorectal cancer today. Today's talk will include epidemiology of colorectal cancer, risk factors and prevention, early detection, diagnosis, and staging of colorectal cancer, treatment, and survivorship. Next. This picture from Mayo Clinic shows us the large intestine. We divide the large intestine to cecum, ascending colon, transverse colon, descending colon, and the sigmoid colon. This is useful for us to locate the colon cancer. Rectum is connected to sigmoid colon. The treatment of rectum is slightly different from colon cancer. So the mass showed in colonoscopy here is an example of colon cancer. In 2020, about 147,950 new cases of colorectal cancer are diagnosed in the United States. Among this, 104,610 cases are colon cancer, and the remainder are rectal cancer. About 53,200 Americans died of colorectal cancer in 2020, accounting for approximately 9% of all cancer deaths. The lifetime incidence of colorectal cancer in patients at average risk is approximately 4% in the United States. Colorectal cancer incidence is approximately 25% higher in men than in women, and is approximately 20% higher in African American than in whites. Next. This is a 2020 estimated leading sites of new cancer cases and deaths in the United States from American Cancer Society surveillance research. As we know, prostate cancer is the most common cancer in men, and breast cancer is the most common cancer in women. Colorectal cancer is the third most common cancer in both women and men. However, lung cancer is the leading cause of cancer deaths in both women and men. Colorectal cancer is the third leading cause of cancer deaths in both women and men. Next. This graph shows more clearly visually. As you can see here, from 1930 to 2017, lung cancer is the leading cause of cancer deaths in men. Colon cancer is the third leading cause of cancer deaths. From this graph, we see overall the cancer-related deaths is decreasing over the years due to better and advanced cancer treatment. Of course, for lung cancer, the decreased lung cancer deaths is also related to decreased use of tobacco. For colorectal cancer, screening colonoscopy play a big role to reduce the colon cancer deaths. Next. For women, lung cancer deaths is much lower than men. Colorectal cancer is still the third leading cause of cancer deaths in women. The rate is slightly lower than men. Next. So what are the risk factors for colorectal cancer? They include aging, history of adenomas, family history of colon cancer, especially first-degree relatives. Single first-degree family member having colon cancer doubles risk of cancer of the rest of family members from 4% to 8% lifetime risk. Familial adenomatous polyposis, history of ulcerative colitis or Crohn's disease, hereditary non-polyposis, and a history of abdominal pelvis radiation, which could be due to previous other types of cancer treatment, such as lymphoma. Next. The age-specific incidence of colorectal cancer was measured between 2004 and 2013 in men and women of all races from this graph. The x-axis represents different age group, and the y-axis represents colorectal cancer rate per 100,000 people. It is very rare to see any colorectal cancer when one is younger than 40 years old. In contrast, the colorectal cancer incidence at age above 80 years old group is almost 6 times more than the person at their 50s. Next. We all know screening colonoscopy. Why we need a screening colonoscopy? Because we are able to detect the colon polyps. Most of colon cancer arising from adenoma. When the colon polyps size is more than 2 centimeters, or it is a stem cell-based polyps, or patient has multiple polyps, or pathology report shows villus polyps, the risk of developing colorectal cancer is significantly increased. Colon polyps present in 25% of Americans who are older than 50 years old. If the pathology report shows hyperplastic polyps, which does not have malignant potential, the treatment of polyps will be polypectomy. That means removal of polyps during the colonoscopy and then followed closely. This little picture in the right side shows stem cell polyps and pedunculated polyps. Obviously, pedunculated polyps are easy to be removed. However, stem cell-based polyps are much harder to be removed completely, which corresponding to the increased risk of colorectal cancer. Next. Familial adenomatous polyposis is an autosomal dominant disease. Usually hundreds of adenomas were found during the colonoscopy. There is a 100% risk of developing colorectal cancer. Colonoscopy can confirm the diagnosis. It is recommended to remove the whole colon when patient reaches 20 years old. Upper GI tract endoscope is also recommended to screen gastric and duodenal polyps in later life. Duodenal polyps has increased risk of developing cancer. The family members of patient with familial adenomatous polyposis needed to be screened. Gardner's syndrome is a subtype of familial adenomatous polyposis. Gardner's syndrome is an autosomal dominant form of polyposis characterized by the presence of multiple polyps in the colon together with tumors outside the colon. The extracolonic tumor may include osteomas of skull, thyroid cancer, epidermal cysts, fibromas, as well as the occurrence of desmoid tumors in approximately 15% of affected individuals. Next. Peutz-Jeghers syndrome is an autosomal dominant genetic disorder characterized by the development of benign adenomatous polyps in the gastrointestinal tract and hyperpigmented macules on the lips and oral mucosa. This syndrome can be classed as one of various hereditary intestinal polyposis syndrome. People can present with small bowel obstruction from intussusception at early life. Patient is at risk for different malignancy, including colon cancer, pancreatic cancer, and breast cancer, etc., at later life. Next. History of Crohn's disease and ulcerative colitis has increased the risk of developing colorectal cancer. From this table, we can see ulcerative colitis mainly present with diarrhea and rectal bleeding. It's mainly involving colon. The lesions is continuous and the pseudopolyps can be seen during colonoscopy. Mucosal and submucosal inflammation will be found on histology. Crohn's disease can involve the ileum and the colon. Diarrhea and rectal bleeding is also very common. Colonoscopy shows discontinuous lesion, cobblestoning, aphthous, and linear ulceration. Strictures also seen on colonoscopy. Usually histology shows transmural inflammation. Next. Next, please. The left picture of this slide shows Crohn's disease, illustrating transmural inflammation, skip lesions, strictures, linear ulceration, and fissures. The right picture shows ulcerative colitis, illustrating pseudopolyps, continuous colonic involvement, which begins in the rectum. The active disease shows superficial ulceration, while inactive disease shows atrophy. Next. Hereditary non-polyposis colon cancer, also called Lynch syndrome. This is an autosomal dominant disease too. If colon cancer is diagnosed in 3 first-degree relatives over 2 generations, with one family member diagnosed colon cancer younger than 50 years old, you should suspect Lynch syndrome. It is more common to have right-sided colon cancer. Lynch syndrome also has increased incidence of other malignancies, which include endometrial cancer, ovarian cancer, kidney cancer, urethral cancer, gastric cancer, pancreatic cancer, and biliary tree cancer. Screening colonoscopy should be started early at age 25. Next. Next, please. The most risk factors previously discussed are genetic, and not too much we can do to reduce the risk. However, the risk factors listed on this slide are something we can do to prevent colon cancer. Studies suggest that obesity is related to increased incidence of colon cancer. Diabetes also has increased incidence of colon cancer. Red meat, such as beef, pork, lamb, veal, mutton, horse, goat, anything you can think about, considered group 2A carcinogen, according to World Health Organization International Agency for Research on Cancer. That means that the consumption of red meat probably is associated with increased risk of colorectal cancer. Processed meat such as sausage, bacon, ham, beef jerky, corned beef, and the other smoked, salted, fermented, or cured meat are considered group 1 carcinogen. Although there may be an increased incidence of developing colorectal cancer associated with the intake of processed meat. The absolute risk is small and only occurs with delayed consumption. And it is not clear that all individuals have the same risk. Modest consumption of red and all processed meat, such as 1 to 2 times weekly at most, is an acceptable part of a healthy, balanced diet. Tobacco not only increases the risk of lung cancer, but also increases the risk of colorectal cancer. Actually, tobacco increases the risk of all kinds of cancer. There is also a report about increased risk of colorectal cancer associated with alcohol consumption. Next. So the strategy for colon cancer prevention is no smoking, no excessive use of alcohol, weight control or weight loss by a healthy and a balanced diet. A low-calorie diet can reduce weight up to 17%. High fiber, folate, calcium, vitamin D, and the dairy product, garlic, fish consumption, coffee intake has been all studied to prevent colon cancer. However, the data is not conclusive. Studies suggested exercise decrease the incidence of cancer development. I have been encouraging all my patients to have regular exercise, which is also helpful to reduce the weight. Some studies suggest aspirin and NSAIDs could be potentially helpful to prevent colon cancer. However, it is not routinely recommended yet. Next. If you want to quit smoking, Robert Wood Johnson University Hospital has this nicotine and tobacco recovery service, which is free. I list the contact information here. Next. As we know, nicotine is a powerful, high addictive drug. On average, people try to quit smoking 5 to 7 times before they successfully quit for good. The Institution for Prevention and Recovery has helped thousands of people to overcome their addiction to nicotine. Our nicotine and tobacco recovery service are staffed with certified professionals who provide treatment under the Public Health Service guidance. Scientific research shows that individuals are 4 times more likely to quit using using tobacco when participating in a structured program as compared to attempting to quit on their own. Services are provided to individuals of all ages in Essex, Mercer, Middlesex, Monmouth, Ocean, Union, and Somerset counties. Most importantly, this is a free program, including free nicotine replacement therapy, such as nicotine patch, gums, and lozenges. No insurance is required. Next. Now we are going to talk about early detection and diagnosis. Next, please. This picture from Harvard Health Publication shows how a colon polyp progresses to cancer. The tumor starts with hyperproliferative cells, then it becomes adenomatous polyps, from small to bigger, then to severe dysplasia, which is a precancerous polyp, then to adenocarcinoma and invasive cancer finally. Next, please. The key of early detection is screening, which include a stool-based test, endoscopic visualization, and a radiographic visualization. Age 50 is recommended to start screening tests in the past. However, American Cancer Society recommended to start screening at age 45 in 2018. United States Preventive Service Task Force also intended to lower the screening age to 45 in 2020. If patient has a positive family history, the screening should start at the age 10 years before. Fecal-based test includes fecal immunochemical test for blood every year. Guaiac-based fecal alcohol blood test, also called FOBT, should be tested every year. However, the sensitivity of FOBT is very low. FOBT is negative in more than half of proven cancer patients. The positive rate is about 2%. The sensitivity about 60%, if you do test 3 times. The positive test mandate workup, ideally colonoscopy. The new stool-based test called a Cologuard, which include a multi-targeted stool DNA testing for KRAS mutation and a fecal immunochemical test for blood. Colonoscopic visualization includes flexible sigmoid scope every 4 to 5 years, colonoscopy every 10 years. Capsule endoscope is approved by FDA for use only in patients who had an incomplete colonoscopy, not as a screening option by itself. We always wonder when to stop screening colonoscopy. There is no clear cut. General consensus is stop screening after age 75 or if life expectancy is less than 10 years. Next, please. After baseline colonoscopy, what is an appropriate interval for surveillance colonoscopy? If patient does not have polyp, he can be followed up in 10 years. If there is a small hyperplastic polyps in the rectum or sigmoid, colonoscopy can be repeated in 10 years. If patient has 1 or 2 small, less than 5 millimeter adenomas, repeat a colonoscopy in 5 years. If patient has 3 to 10 adenomas or 1 adenoma larger than 1 centimeter, any adenoma with villous feature, including villous or tubular villous feature, any adenoma with a high-grade dysplasia, repeat colonoscopy in 3 years. If patient has 10 adenomas, repeat colonoscopy less than 3 years. Polyps that are removed piecemeal requires repeated colonoscopy in 2 to 6 months. Next, please. Here is a colonoscopy indication besides screening colonoscopy, which include occult bleeding, iron deficiency anemia, gross low GI bleeding, which does not include a bright blood rectal bleeding in a young patient, which might be due to hemorrhoid. Abnormal Barron enema, adenomatous polyps on flexible sigmoid scope, history of colon cancer, family history of colon cancer, started screening at age 10 years before, as we discussed before. FAP, Lynch syndrome, inflammatory bowel disease followed up and surveillance. If patient has bacteremia with Streptococcus bovis or Clostridium septicum, ischemic colitis, decompression after an acute attack of diverticulitis, in which colonoscopy needed to be performed in 4 to 8 weeks later. Next, please. This table shows the symptoms associated with colorectal cancer. DOI stands for diagnostic odds ratio. If DOI equal 1, that means no association between symptoms and cancer. DOI is 2.6 for rectal bleeding, 3.1 for blood mixed with stool, 3.9 for dark red blood, and 3.9 for weight loss. These symptoms have a statistically significant correlation with colon cancer. P-value is less than 0.01. Next, please. Now we're going to talk about colon cancer staging. Colon cancer can be staged into stage 0, stage 1, 2, 3, and 4. Stage 0 to 2 is localized disease within colon. Stage 3 means cancer has spread to local lymph nodes. Stage 4 means tumor has spread to other organs. This is a structure of colon wall on the right side. The inner layer is mucosal, and then submucosal muscle layers and serosa. Next line, please. Next slides. Colon cancer staging using both TNM and Duke stage. Stage 0 is an intramucosal carcinoma, also called carcinoma in situ. Stage 1 or Duke stage A, tumor confined to the mucosal and submucosal. 5-year overall survival more than 90%. Stage 1, Duke stage B1, tumor extending to muscle layer. 5-year overall survival is around 85%. Stage 2, it's Duke's stage B2, tumor extending to serosa and beyond the serosa. 5-year overall survival is about 70 to 80%. Stage 2, that's Duke's stage C, tumor involving regional lymph nodes. 5-year overall survival is about 35 to 65%. For stage 4, Duke's stage D, with metastatic disease, 5-year overall survival is only about 5%. Next, please. Now I'm going to briefly introduce the colon cancer treatment. This is a general principle. Of course, everyone's condition is different, and we offer personalized treatment according to patient's unique condition. In general, stage 0 to stage 3 disease needs surgical resection. Radiation is not indicated. Stage 0 patient also can be treated with a polypectomy or local excision in certain condition. Stage 2 patient with high-risk features might need adjuvant chemotherapy with FOLFOX or Kpox. I will introduce chemotherapy medication later. Surgery is not indicated for stage 4 colon cancer. However, if tumor is causing obstruction or the bleeding associated with tumor is not able to be controlled by conservative measure, palliative surgical resection could be performed. Some patient could be surgical candidate for isolated liver, lung, or peritoneal lesions. Chemotherapy for stage 4 colon cancer is very complicated, involving different regimens and multiple lines. Radiation might be used for some patients with oligo, lung, and liver metastasis. The modality include radiofrequency ablation, stereotactic body radiation therapy, also called SBRT, or chemoembolization. Next slide, please. For stage 2 and 3 rectal cancer treatment, it is different from colon cancer. The traditional treatment in this condition is neoadjuvant concurrent chemoradiation in 25 to 28 fractions, followed by surgical resection, about 4 to 8 weeks after finishing chemoradiation, then followed by 4 months of adjuvant chemotherapy with FOLFOX. Currently, total neoadjuvant chemotherapy, also called a TNT, is preferred, followed by surgical resection, especially for patients with a high-risk patient, T4 lesion, lymph nodes positive. The benefit of TNT include improved delivery of planned therapy, increase the downstaging, early elimination of micrometastasis. It also provides an opportunity for in vivo assessment of chemosensitivity. It alleviates the need for post-operative therapy, reducing duration with diverting ileostomy, and saving patients from undergoing chemotherapy with a stoma. So basically, you get a chemotherapy first, followed by chemoradiation, and then followed by surgery. Next, please. For the metastatic colorectal cancer, molecular testing is very important to help choose the appropriate personalized therapy. I listed here the most common tests that we are doing now. If patient has KRAS, NRAS, BRAF wild type, cetuximab and panitumumab can be used in the metastatic setting. If patient has a microsatellite instability or mismatch repair deficiency, immunotherapy can be used. High tumor mutation burden is also indication for immunotherapy. We have a targeted therapy for colorectal cancer with a positive tropomyosin receptor kinase fusion. For HER2 positive patient, anti-HER2 treatment also can be used. Next, please. Here is the chemotherapy and a biologic medication used in colorectal cancer. The mainstay of chemotherapy medication is 5-FU, which has been used for years. 5-FU plus oxaliplatin is a regimen called FOLFOX. Capecitabine plus oxaliplatin is a regimen called CAPOX. 5-FU plus irinotecan is regimen called FOLFIRIA. That's like most regimen we used. Lonsurf is used at a later line. On the right side, VEGF inhibitors are used to inhibit angiogenesis of tumor. EGFR inhibitors are used for KRAS, NRAS, BRAF wild type tumor. Next slide. Next slides, please. Here is a list of medications of immunotherapy, TRK inhibitor, BRAF inhibitor, and anti-HER2 antibodies. Next one, please. Cancer treatment in the United States is very standard. Most oncologists follow the guidelines from National Comprehensive Cancer Network. Here is an example of metastatic colon cancer treatment. If patient has good performance status and appropriate for intensive therapy, we have all those options as a first-line treatment on different conditions. Next one, please. If patient has progression of disease on first line of treatment, then NCCN guideline has subsequent therapy recommendations. It is very complicated. It is an art to treat the patient. We have to tailor the treatment according to patient's physical, mental, and pathological conditions. I think that's what we oncologists for. Next, please. With advanced treatment, we have more and more cancer survivors. The goal of follow-up include surveillance for recurrence or second cancers, encouragement of healthy lifestyle that minimize cancer risk. As discussed before in colorectal cancer prevention, same principle applies here. Healthy, balanced diet, avoid weight gain, appropriate amount of exercise, minimizing alcohol intake, refraining from smoking. Observation studies suggested that use of aspirin and other NSAIDs may improve survival among patients receiving treatment for early colon cancer. However, prospective confirmation of the benefit of aspirin in a randomized trial is needed before routine use of aspirin can be recommended. to colorectal cancer survivors, given the potential harm, mainly GI bleeding. Survivorship also include treatment of psychosocial and medical consequence of cancer and its therapy, management of comorbid disease in this generally older population. Next, please. There are multiple professional guidelines regarding post-treatment surveillance for resected colon and rectal cancer. In general, patient needs to be followed every 3 to 6 months for the first 2 years after finishing treatment, then every 6 months for 3 years. We will check tumor markers CEA every 3 to 6 months for 2 years, and then every 6 months for total 5 years. Imaging study, such as CT scan, also recommended every year for up to 5 years. Surveillance colonoscopy is also recommended. Therefore, colon cancer survivors usually followed by primary care physician, surgeons, medical oncologist, and gastroenterologist. Next. Thank you for your attention. This is our Regional Cancer Care Associate Central Jersey group. That's all for today, and if you have any questions, I'm happy to answer. Jennifer?
Hi, and then if you have questions, please go ahead and put them in the chat window, and I can repeat them for the doctor so that we don't have any privacy concerns. I actually did have one question. I wasn't clear on the difference between an adenoma and a polyp. Can you explain that a little more clear? Explain that again.
Okay, so polyps is a form of lesion you're seeing. It is not cancer yet, but it's kind of protruding on the colon wall. And adenoma is more pathology diagnosis. So when you cut off the polyps and look on the microscope and you see whether it's adenoma, it's a villous adenoma, like a tuberous adenoma. So, and also like a hyperdysplasia. It's different type of pathology report.
So you wouldn't know that until you had received the pathology report.
That's right. It only happens after you get a polyp removed and the pathologist reviewed it, and then they will tell you it's adenoma or it's what type of adenoma.
Okay, somebody else asks, do probiotics for leaky gut syndrome have any bearing on colon health?
Probiotics?
Yes.
Can you repeat the question again, please?
Mm-hmm. Do probiotics for leaky gut syndrome have any bearing on colon health?
I'm not sure. Actually, I didn't see any, as the material I reviewed, and I didn't see anything about probiotics, whether able to prevent colon cancer, any benefit of preventing colon cancer. I didn't see it, so I'm not sure. And what's the role of a probiotic? I mean, lots of people try to, treat the diarrhea. Yeah, that's I think that's most useful. I think for of course, like people have irritable bowel syndrome. I think probiotic was used, and also for diarrhea. I guess gastroenterologists will have a better answers on that.
Now you did say, this is a follow-up question, you did say that IBS is a finding that indicates closer tracking, though it's less concern than Crohn's or ulcerative colitis. Is that correct?
Oh, that's a two different entity. So I'm talking about IBD. It's inflammatory bowel disease. So that's include ulcerative colitis and also Crohn's disease. IBS is irritable bowel syndrome. So that's a syndrome patient can have like a diarrhea, constipation, alternation of those symptoms, and might don't have much, pathological change as an inflammatory bowel disease. So more functional, irritable bowel syndrome is more functional.
Thank you. Does anyone have any more questions? I'm gonna. If you're interested in getting in touch with the Regional Cancer Care Associates, they can be reached at their website, www.centraljerseyrcca.com, or at phone number 888-824-8312. The library can be reached at www.plainfieldlibrary.info, info. This recording will be available on the library's YouTube channel, and we will send out a notification to everybody who registered when that recording is available. We expect it to be available in the next day or so. Are there any other questions? Then I really like to thank Dr. Pan for her wonderful presentation, and Regional Cancer Care Associates for making this presentation available. And thank you all for attending.
Thank you, Jennifer. Thank you for having me.
All right, I'm gonna start to close the meeting then. All right, thank you again.
Thank you. All right, have